Okay, so picking up where we left off. So this is a picture, it's in your textbook as well. It's representative of an interferential current. So as we said, with interferential, you're using two channels, and the two channels kind of superimpose on one another. They create what's called a constructive interference effect. So you see these are your two carrier frequencies here. So when you run these two carrier frequencies, you end up getting your resultant beat frequency here. And this is what creates that kind of medium frequency current where you get a little bit of a deeper penetration as far as the stim is concerned. It also tends to be a little bit more comfortable. But that's what you get with interferential. So you need the two channels in order to do that. You get that constructive interference effect, and that's the resultant effect of stim with the interferential current. You also want to make sure that the channels cross each other. So you actually want to kind of crisscross the pads, crisscross the channels, and that gives you your result effect with the interferential stim. So premodulated interferential, it's a time-modulated alternating current, and it uses bursts of medium frequency. So essentially what premodulated is, it's basically two-pad interferential. The difference is, instead of that kind of the two channels having the constructive interference in the body where you have the four pads, now it does it within the machine. So you only need two pads for premodulated interferential. So it's two. You're just going to determine your treatment goals based upon what it is you want to accomplish: sensory pain modulation, muscle spasm reduction, or neuromuscular stimulation, and you'll just adjust the frequency. Remember, frequency is the same when you're looking at sensory pain modulation, noxious pain modulation, rhythmical pain modulation. If you're looking at neuromuscular stim, which we're going to talk about more extensively in the next one, the frequencies are all the same for all the waveforms, so that doesn't change. So you just have to basically match your goal with what it is you're applying with the electrical stim. So again, premodulated and interferential, they're the same type of waveform. The difference is clinically why you'd pick one over the other is if you only need two pads, so the body part area you only need two pads for, use premodulated. If you can use four, use the regular interferential. Okay, high voltage stimulator. So high volt gets classified anytime you get greater than 150 volts, and high volt is considered a twin peaked monophasic current. Okay, so a lot of people tend to think, because they only see the charge on one side of the current, they tend to think it's direct current. So high volt is not direct current, it's monophasic. The reason why it's not considered a direct current is because, again, it's still pulsed. Okay, one of the things that you have with this, you get a little deeper penetration. There's a very short phase duration with high volt. Okay, there's a short duty cycle, so the intrinsic duty cycle is very short. So there's less skin resistance, so it does tend to be very comfortable and does tend to be a very deeply penetrating electrical stim. There is a polarity difference. Now, if you do a monopolar setup with a bigger dispersive pad and a smaller active pad, you can use kind of the purported benefits of having a positive or negative current over the treatment area. Otherwise, if you don't necessarily want to do that, you can just do you can basically just do a bipolar treatment. The pads can be the same size, and you just set up your parameters accordingly. Uses: pain control, edema reduction, tissue healing. We'll talk about the tissue healing and some of the things with wound healing and how you'd want to set that up. Edema reduction. Now, for edema reduction, you could either use it in a neuromuscular fashion for a muscle pump, or there is potential of using a monopolar treatment with the negative electrode. I'm going to talk about that a little bit on the next slide, but that's kind of a different, most of the time if you're doing edema reduction with electrical stim, you're trying to get a motor response or a muscle pump. You're trying to basically get the muscles to pump to help the lymphatic system remove the edema. With high volt, you can do a monopolar negative treatment over the area to theoretically possibly get some edema reduction from that. We'll talk about why that occurs on the next slide. If you're looking for tissue healing, wound healing, you would you would kind of follow the natural healing current with it. So you start positive, then switch to a negative treatment. The negative treatment increases vascularity, fibroblasts, collagen and epidermal migration. It also inhibits bacterial growth. Positive charge increases macrophages, epithelial growth, and encourages clot formation. So you would start, they typically say start with the positive, then switch to negative when you're doing wound management or for tissue healing. Okay, so again, typically it's a monopolar technique with high volt, depending upon what it is you're doing. So again, the idea there is you'll have a smaller active electrode to kind of concentrate the charge in a larger dispersive. The larger the distance between the electrodes, and this would go for any type of stim, you would get deeper penetration. So even if you're just looking at any type of stim, the further you put the pads apart, the deeper it tends to go. You can also just use a typical bipolar technique. So if you're not looking to get any of the benefits from having just a positive or negative charge over the treatment area, if you're just doing basic sensory pain control, neuromuscular re-education, strengthening, you could just do 2 pads that are the same size and just use the frequency according to what it is you're trying to do. You can do some appendage submersion with active range of motion, so you could do underwater treatment with this. If you're using it for the edema reduction, so the classic formula for edema reduction is to start with a negative charge. So what you'd essentially do with the monopolar treatment for edema is start with a negative charge, 100 pulses per second, so pretty high frequency, and then over time you would eventually switch over to a positive charge. So ionophoresis, I talked about this a little bit in class. So when ions in solution are transferred through the skin via an electrical potential, so what you're essentially looking to do is you're looking to take a medication and actually drive it through the skin. Unlike phonophoresis, which we said, the research is kind of iffy on, some people still do utilize it. Ionophoresis is found to be pretty effective. The depth of penetration is not very deep, so it does tend to work better in more superficial regions. So if you think of like some superficial regions, this tends to work really well with that. This is a monophasic, but it's also a direct current. So really the most common direct current that we use typically in athletic training settings is going to be ionophoresis, because the only other real application of pure direct current, meaning that the current stays positive and negative and is just continuously on the entire time, is for denervated tissue, which we don't tend to really deal with that a whole lot. With ionophoresis, you need that because you need the very strong polar effect in order to drive the medication through the skin. So you have the anode, which is the positively charged side, the cathode, which is the negative. The idea is that you have to know the charge of the ion or the medication that you're using, because you have to match that with the proper electrode. So in other words, if you're using a negatively charged medication, you have to put that on the cathode or the negatively charged pad, because that's what's going to help drive it through the skin, because like repels like with the charges. You have to check with your state practice act since you're administering a medication. Again, look with your state practice act and how that would be kind of regulated. Most physicians, so for instance, in the state of Pennsylvania, you work directly under the supervision of a physician. A lot of times the physician will write a standing order for certain things, and that could be the case with something like this where they put in a standing order, but you just have to make sure you have that paperwork in place. You want to make sure that you match the polarity of the medication with the electrode, just like I said. So again, because if you don't do that, the medication is not going to get driven into the skin. And you just want to monitor for skin irritations and burns. So, and it does sometimes happen. Athletes will sometimes get small blisters or skin irritations. I just warn them about that ahead of time, just to give them a heads up. When it does happen, it's usually not a big deal. Some people, though, obviously can have more sensitive skin than others and things like that and react to the medication. If by chance they do get some irritation, just don't reapply it over that same area. If they just have like a small blister or something, see if you could kind of move the pad away from there, at least until that heals. But usually you don't get too many issues with that. They also just recommend about 6 inches between the active and dispersive electrode with the ionophoresis units. So that's something to consider as well. So put them about 6 inches apart when you're setting up the patient. So here are the common medications used with ionophoresis. So make sure you familiarize yourself with the polarity charge. So you're going to have to make sure that you put the polarity, you have to match the polarity to the lead. So all the negatively charged ions have to go on the cathode, all the positively charged have to go on the anode, okay? Probably the most common ones utilized, dexamethasone, very common to use. I'd probably say clinically I've used dexamethasone the most. That's an anti-inflammatory. Lidocaine is basically a numbing agent, so it causes an anesthetic effect. Salicylate, hydrocortisone are both anti-inflammatories. I have used some acetic acid for calcium deposits. If an individual seems like they're starting to get a calcium deposit, I think I've used that at least once, I know, and it seemed like it was pretty effective. It did cause some minor skin irritation, but the individual was okay with it, and we were able to continue to use it. A microcurrent stimulator. Now, microcurrent is kind of different. So microcurrent doesn't involve nerve fiber depolarization. So the reason why it's called microcurrent is because the intensity is in the microamperage range. So it's a little bit different as far as the intensity and everything is concerned. You're not stimulating nerve fibers. There's little evidence of this. Very commonly people have tried to use this to help heal tissues. There's little evidence of repair in humans. They do think that it could possibly help in pain relief, but obviously the pain relief mechanism is much different because you're not getting nerve fiber depolarization. It has been found to be effective for slow healing skin wounds. So basically what you're looking at here is a combination of DC and pulsed interrupted current. So it is basically a direct current, but it's also interrupted, which, kind of sounds counterintuitive, but if you were to look at what microcurrent looks like from a picture perspective, that's what it would look like. It would basically be a broken up direct current. Here's all I really want you to know as far as microcurrent is concerned. So if you were going to use it for healing, you want to be between 20 and 60 microamps for the intensity, and about 0.3 for the 0.3 hertz for the frequency. For pain control, you're just going to increase the intensity and use a higher frequency. Again, some of the research on microcurrent is just kind of getting looked through. It does, however, it has been shown to show some effects. So I'm not going to say it's not a good waveform to use. It's just that it's still kind of being looked into as far as some of the effects that it has, unlike some of the other waveforms that we previously discussed. So I briefly talked about combo a little bit in class, and again, this is the combination of ultrasound and stim, and where you're actually using the ultrasound head to both transmit both ultrasound energy and electrical stimulation. And the key with this is just select your parameters based on your treatment goals. So the biggest thing is with the stim is, are you using it for motor purposes or are you using it for sensory? And you would basically set your parameters based on that. I discussed in class how I most commonly would utilize this as a form of to release trigger points and tender points in the muscle. So I tend to use motor stim. I also do tend to use pulsed ultrasound only because I kind of use a trigger point method where I tend to hang out over areas of top muscle, and if you do that with continuous, that could get a little uncomfortable for the patient. You can use continuous and you can get a temperature increase if you like. I tend to just use the ultrasound for the pulsed ultrasound for the mechanical effects. Your contraindications for stim. and we have these are all different contraindications that you have, and I mentioned specific ones. We break this down a little bit further in lab, but this is commonly what you'll see. So you never want to put electrodes over the carotid artery, anywhere near a cardiac pacemaker. You don't want to run the pads transthoracic, so you don't want to run them across or through the thoracic region, over the heart or brain, over malignancies. Pregnancy, which I'll talk about pregnancy a little bit in class. You obviously don't want to put the pads over the abdomen of a pregnant individual, but certain waveforms, you can actually still use them during pregnancy in unrelated areas. Medication allergies with ionophoresis or over recent non-union fractures. So the summary, again, treatment goals should guide the selection of the device and parameters. I mean, really, again, for the most part, your parameters all stay the same. So that's kind of the nice thing. So there's a lot of information on STIM, but what it really boils down to are those simple parameter ranges that are the same for all waveforms. So if you sit there and say, well, how do I know which waveform to pick? Well, let's just take picking between interferential and premodulated, okay? So we said interferential and premodulated are essentially the same waveform. The only difference is between 4 pads and 2 pads. So think to yourself, why would you choose a 4-pad treatment over a 2-pad treatment? Well, most commonly you look at the body part area and see how you would cover it, okay? Other than that, everything else stays the same. It wouldn't matter if you're using it for sensory level pain modulation. Your parameters are the same between both of them, okay? They all fall within those parameters that we discussed. It doesn't matter what waveform you select. Again, some units and waveforms yield the same physiological responses. So again, some of it comes down to personal preference. Some of it might come down to what body part's injured. That you can get, as long as you're getting the appropriate physiological response, you're getting it. So again, understand how pain modulation theories can be used to adjust parameters. So again, you may have to go back and review those different levels of pain control. Safety and contraindication should be considered just as like anything else. And here are your learning outcomes.